Hi, welcome everyone. I'm Dick Deming. I'm Medical Director of Mercy One Cancer Center and the founder of Above and Beyond Cancer. Welcome to our Cancer Education Series, which is brought to you with some funding from the Iowa Cancer Consortium. And I'd like to welcome my guest, Ryan Dornbier. Ryan is a Des Moines native, went to high school at Dowling, and then went to St. Louis University for his undergrad and medical school. Did his residency in urology at Loyola Chicago, and then did a fellowship in men's urologic reconstruction. And he's been here with Urology of Central Iowa.
Urology Center of Iowa.
Urology Center of Iowa, UCI, Urology Center of Iowa, and for about a year now. And I've enjoyed working with Ryan and asked him to be on our podcast this evening to talk about some of the urologic issues and some of the sexual function issues for men who undergo prostate cancer treatment. So as a urologist, prostate cancer is one of the most important diagnoses that you guys take care of.
Yeah, it's absolutely something that we see on a very regular basis, and really through the initial evaluation and concerns for prostate cancer with an elevated PSA, all the way through treatment and recovery, and sometimes even to advanced therapies for any sort of recurrences or anything like that. So it's definitely something that we have a lot of experience with and see the full gamut of presentations and overall care of.
Yeah, so prostate cancer is the most common cancer in men. I've been in practice for over 40 years. There's been a little bit of change in the focus of what we think about for screening cancer, prostate cancer. Back when I was first in practice, it was considered essential that every man be screened for prostate cancer with PSAs. And over the last decade or so, that has changed a bit in the way that we talk to men about the value of screening. What would you say is the perspective you have?
Yeah,
having trained quite recently.
It's interesting from a new training perspective how the PSA or prostate specific antigen was scrutinized. Really about 10 years ago in 2012, I think the United States Preventive Service Task Force changed its recommendation a little bit to the ire of some practicing urologists, but really it kind of gave us a little bit of a wake-up call to say that maybe we're being a little too aggressive, or we need to find some different modalities to work up patients who have an elevated PSA to avoid aggressive testing or unnecessary procedures to ultimately diagnose prostate cancer, but in a lot of cases do biopsies for benign reasons. And then waltzed in about 7 years ago the MRI of the prostate, and what's called the multi-parametric MRI, which has really changed how we focus on the PSA. And I think starting over the last 4 or 5 years has decreased the number of biopsies that we do, and ultimately the number of clinically insignificant cancers that we diagnose. So I think that whole process really shaped, and in a good way, how we look at prostate cancer.
And so for those who might not know, PSA, as Dr. Dornbeer said, is prostate specific antigen. That's a blood test. And it used to be the standard that every man, when they hit 50, had an annual blood test. And if the blood test was elevated, that led to a biopsy. We know that many times we found types of cancer that was probably insignificant and wouldn't have resulted in health problems had it gone undetected. So now there's other tests that can be done that help determine whether we think this elevation of the PSA really is due to a type of prostate cancer that needs attention. And that has led to fewer men needing to have biopsies and fewer men needing to have a more radical form of treatment.
Yeah, the way we've changed our practice has allowed us to really focus on those men who probably have prostate cancers that are going to be more significant or play a role in their future life, because kind of, as you mentioned, prostate cancer is very commonly diagnosed in men, but if you look at the natural history of prostate cancer, it ultimately doesn't result in death in many men, because it does grow so slowly, and therefore we really need to do a good job at investigating patients who we think the cancer is going to play a significant role in their life.
Because we find a lot of cancers that aren't going to cause a health problem, and then we do treatment, we haven't done patients a favor. And so when I was back in training, there was this study that was often quoted, and I'm just curious whether that if you an autopsy study on men 90 years old and older who died of other causes, and if you did an autopsy and sliced and diced the prostate, you could find a form of prostate cancer in about 90% of the 90-year-olds.
Yeah, that's fairly true. We know that prostate cancer in younger men is not very prevalent, but as you get into the 8th and 9th decade of life, that the development of prostate cancer goes up fairly exponentially. So most men are going to die with prostate cancer, but not die of prostate cancer.
So fortunately, those prostate cancers tend to be very indolent, meaning slow growing, and tend not to spread outside the prostate gland. And if you've just got a little bit of cancer in your prostate, you and your cancer cells can peacefully coexist for decades.
Yeah, and that's kind of one of the things that even if we diagnose the prostate cancer, we try and figure out which of those men can peacefully coexist and which ones need to not peacefully coexist.
Yeah. Talk a little bit about active surveillance. Explain what active surveillance is in terms of prostate cancer.
Yeah, so active surveillance kind of is after the initial diagnosis of prostate cancer. We try to risk stratify men into a category of, do we think this is going to be a cancer that will affect you long term? And for many men, especially those diagnosed with what's called Gleason 3+3 prostate cancer, or fairly low risk prostate cancer, the overwhelming evidence suggests that it won't. So instead of reaching towards active treatment, which would be removal of the prostate or radiation to the gland to attempt to eradicate the cancer, we essentially follow that peaceful coexistence actively, as the term suggests, and that typically involves monitoring the PSA level to make sure that it doesn't increase rapidly. And then oftentimes will also involve a repeat biopsy, usually within the first year after the initial diagnosis, and then again at 2 to 3 year intervals to make sure that there isn't progression of the cancer to a more significant form. And now MRI is also coming into play with active surveillance protocols, partially to follow lesions if they exist in the prostate to see if they are expanding or pushing the boundaries of the prostatic capsule.
So before doing MRI specifically of the prostate, generally the assessment of the prostate was done by what we call a digital rectal exam, and that's the physician inserting a finger in the rectum and feeling the prostate. You only feel the back edge of the prostate. If you've got a very large, lumpy, bumpy, hard prostate, you can detect it. But most men with prostate cancer, that is not a very sensitive way of detecting prostate cancer. MRI, you see all of the internal aspects of the prostate gland, and with contrast, cancer cells can light up, and it can be very helpful. And certainly doing MRI after you've been diagnosed a year later is a more accurate way of determining whether the cancer has progressed, rather than just a digital rectal exam.
Yeah, MRI has also helped us fairly significantly in how we biopsy the prostate, because we used to do what was called a standard template biopsy, which would biopsy the area of the prostate called the peripheral zone, which is the most common area to find prostate cancer, but there are other anatomical regions of the prostate that also can develop cancer. And so what would happen is men with an elevated PSA would come in, they would get their standard biopsy of just the peripheral zone. And then if their PSA would remain elevated and there was still significant concern, that we would do what's called a saturation biopsy, which would basically take a lot more samples of a lot more areas of the prostate, but still kind of randomly around the gland, which might just mean that we missed the cancer if it exists. Whereas MRI has now allowed us to find the internal lesions in the prostate and then allowed us to specifically target those lesions during our biopsies so that we can more accurately diagnose cancer.
Yeah, so it helps you target the place that's most likely to have the cancer.
Absolutely.
When it comes to treatment, historically, surgery and radiation, so I'm a radiation oncologist, have been the traditional main forms of treating prostate cancer. Over time, there's been some new modalities. One question I would have, and I'm aware that cryotherapy, which is freezing, has been around for a while, but I have to admit, I have never in my career ever had taken care of a patient who's had cryotherapy as treatment for prostate cancer, definitive treatment. I understand that maybe it's coming back around as a legitimate way of attempting to cure early stage prostate cancer.
Yeah. So focal therapy, cryotherapy being one. Another one is called HIFU, or high intensity focused ultrasound. And other forms of focal therapy are definitely being actively looked at now. They aren't quite considered the standard of care compared to, prostate removal or radiation to the gland for definitive treatment. And right now we kind of reserve them for clinical trials or for men who might not be able to stand the rigors of either prostate removal or radiation. But there definitely is some data in the pipelines and some trials undergoing right now to determine if focal therapy might be, the wave of the future, because now we can use that MRI and actually focus on those specific locations that have cancer, as opposed to thinking about prostate cancer as a whole gland disease.
Right, because traditionally, I mean, I don't know anybody that removes part of the prostate intentionally. So if you're going to have surgery for prostate cancer, you remove the entire prostate gland. If you're going to have radiation for prostate cancer, we treat the entire prostate gland. So with new imaging, I mean, is it going to be possible that we find prostate cancer in just one part of the gland? And are there techniques to just treat the cancer and not the whole gland? So that would be a real, as we would say, paradigm shift in the treatment of prostate cancer.
Definitely, in terms of the way we think about it. I know definitely, at the University of Chicago and up at Mayo Clinic right now, they're actively investigating those therapies. And there's some intense focus on, those focal therapies.
Well, let's talk a little bit about treatment. So why don't you describe what a prostatectomy would be for someone that you're going to treat with curative intent, organ confined. Prostate cancer, by all the tests and scans, appears to be confined to the prostate gland, and surgery is going to be the definitive treatment. What would that consist of?
Yeah, so as you mentioned, surgery for clinically localized disease. After diagnosis, you'll have probably a couple more imaging studies just to make sure that everything is confined to the gland. But once you have been deemed clinically localized, then prostate surgery or radical prostatectomy is removal of all of the gland, as well as what's called a pelvic lymph node dissection, which removes some of the lymph nodes and lymphatic tissue in the pelvis around some of the major blood vessels. So that procedure has, again, evolved over the course of the last 30 to 40 years. And now probably 95% of the time is performed what's called a robot-assisted laparoscopic radical prostatectomy. So you would have several small incisions across the abdomen, and then using the assistance of robotic technology, which is a surgical device that helps with visualization and kind of micro movements in the operating room, we would remove the prostate from underneath the bladder and its attachments to the urethra. And then after the prostate is removed, we reattach the urethra and the bladder together without the prostate there. And then a little bit larger of an incision is made to remove the gland. The patient would ultimately usually be in the hospital overnight just for monitoring purposes. They would have a catheter for anywhere from 7 to 10 days, and then would come back to the office to remove the catheter. And then full recovery, I usually say, is about 6 weeks until they can go back to their full slate of activities and working out and riding bikes and doing all that kind of stuff.
Okay. And so just for comparison, radiation, if someone were to have radiation for organ confined treatment, what's happened in the world of radiation. So in the world of surgery, we've gone from open surgeries to robotic. In the world of radiation, we've gone to imaging guidance with the radiation that allows us to be more accurate and precise. And as a result, a higher dose per day and fewer treatments. So when I started, you might do 8.5 weeks once a day, Monday through Friday, for 43 treatments for prostate cancer. Now with stereotactic radiation, it could be done in 5 treatments. A more common regimen might be 28 treatments if we want to treat a little bit bigger area, but significantly higher dose per day and fewer treatments. One of the differences is that it does take a while to do the treatments, but each treatment takes about 10 minutes and patients can work through the treatments. Both treatments have side effects and acute side effects while we're going through the treatment, and then delayed side effects as people recover. And I want to talk a bit about side effects because right now I focus a lot of my career on cancer survivorship and seeing patients, a year later, 2 years later, 5 years later, 10 years later. And some of the side effects of cancer treatment, some of the chemotherapy side effects and radiation side effects don't show up right away. When we're dealing with the prostate, a couple of the big side effects that can happen is loss of total control of urination, called incontinence, and loss of the ability to get erections, erectile dysfunction. What sort of conversation do you have with men prior to a prostatectomy about what to expect when it comes to those sorts of side effects?
Yeah, absolutely. The long-term, quality of life measures following a prostatectomy are definitely the worst part of the disease and the survivorship a lot of times for men. And so we have a conversation about the anticipated recovery. Post-surgical things and things in the immediate, kind of as you mentioned, are things related to the surgery, but the incontinence and the erectile dysfunction are definitely the long-term effects. So one, from an erectile standpoint, most of your erectile quality after a prostatectomy definitely depends on your erectile quality before the surgery. So by no means is removing your prostate going to improve your erectile function. And so if you don't have erections beforehand, you're probably not going to have erections afterwards. The second thing is, if you do have good, strong erections beforehand, there's going to be a decline in the quality of those erections, at least in the immediate postoperative period. 90% after 2 weeks following the operation will not have potent erections, and it's probably closer to 100%. But then the recovery starts at that time frame, and typically recovers to about a year to 2 years after the prostatectomy. However, even after full recovery, and the studies vary, but will be about 50% will have a decline in the quality of their erections, and of that 50%, 75% won't have erections again without some sort of medical assistance or treatment to their erectile function.
We'll talk a bit about the treatments in a bit, but what about those men who are able to get erections? Do they have ejaculation? Is there fluid in the ejaculate? And do they have a sense of orgasm?
Yeah, so you do not have ejaculate any longer, because the structures that have the largest impact on the volume of your ejaculation are removed during the prostatectomy, the prostate and the seminal vesicles. And therefore you would have a dry ejaculate, but you do still experience orgasm. Occasionally, and this is another kind of side effect that goes along with that incontinence, but an important part about sexual quality and function after a prostatectomy is that occasionally you do have leakage of urine with an ejaculation, which is called climacturia, which is also something that can be addressed, but also should be discussed before the prostatectomy.
Gotcha. Is there a loss of sensation, like on the head of the penis or the shaft of the penis?
Typically, no. Sometimes in the initial postoperative period, when the nerves from around the prostate, which supply the nerve supply to the penis as well, you will have a little bit of delay to ejaculation, but typically once your erections are addressed, that delay resolves.
Okay. Let me talk a little bit about radiation, and then we're going to start talking about what to do to help with men who have side effects related to prostate cancer treatment. So with radiation, the radiation is given slowly, and the acute side effects, meaning the side effects you have while you're getting the radiation, are primarily related to some radiation effects on the bladder and radiation effects on the rectum. So while going through, let's say, 6 weeks of radiation, you might experience increased frequency of urination due to irritation of the bladder and increased frequency of bowel movements due to irritation of the rectum. Those usually resolve within 6-8 weeks of the radiation. The delayed effects of radiation are where some of the more significant side effects kick in. So as you mentioned, Ryan, the main volume of the liquid that comes out in ejaculation comes from the prostate gland. When you do radiation, you don't get rid of the prostate gland, but the radiation, which is intended to kill the cancer cells, doesn't kill all the prostate cancer cells, but it definitely reduces the secretions. So just as an analogy, if I treat someone with throat cancer and I treat their salivary glands, they forever have a drier mouth because the salivary glands don't make as much saliva. When you treat the prostate with radiation, it definitely reduces the amount of fluid, mucus material that's made by the prostate. So there's significant reduction in the volume of the ejaculate. Most men after radiation remain, and as you pointed out, if we're treating somebody that's 75 and already having erectile dysfunction, radiation doesn't make erectile function better. The statistics are about 50% of men 5 years after radiation may start having erectile dysfunction as a consequence of the radiation, and it's related to the scar tissue that happens as a delayed effect of the radiation. But as a result, erectile dysfunction can be a side effect of either surgery or radiation. Usually urinary incontinence isn't a side effect of radiation, but the opposite could happen, is that radiation can cause scarring and narrowing of the urethra that can make the flow of urine be diminished, the force of the stream. So sometimes after radiation, stenosis or narrowing of that urethra needs to be corrected by a dilation procedure.
Yeah, the post-radiation strictures, which is that narrowing of the urethra, can happen in multiple locations throughout the urethra, and that narrowing can sometimes be addressed with dilation, but sometimes repeated dilations are necessary, and in which case sometimes a larger procedure to repair the urethra is necessary, what's called a urethroplasty, which after radiation, because sometimes the tissue is very scarred, can heal, but ultimately lead to that incontinence of a more stress-related nature.
Gotcha.
Which then would have to be addressed similar to the way post-prostatectomy stress-related incontinence would be addressed. Stricturing, though, after radiation isn't all that common. It's more common, I think, with certain types of radiation than others, namely brachytherapy, I think, much more frequently so than from general external
and
beam
brachytherapy
radiation.
is a form of radiation where you put the radiation seeds, radioactive isotope, up inside the prostate, either permanent seeds or temporary. So let's talk about management of erectile dysfunction and management of incontinence. So, as I mentioned, Dr. Dornbeer has a fellowship in reconstructive surgery in male urology and is the only person in central Iowa that has that fellowship. So, he has special training in the management of these two entities. So, why don't we
Yeah.
start with which one do you want to start with?
Let's start with, well, I like to start with incontinence,
Okay.
partly because I think definitely from a survivorship standpoint, when incontinence is bad, it definitely has a much more uh, problematic and isolating feeling than I think erectile dysfunction does. And the reason that is because when you have post-prostatectomy incontinence, you can have variable levels of it, but basically you need to wear pads, sometimes diapers to collect the urine to prevent it from getting on your clothing, and therefore men can feel socially isolated or avoid social events and things like that. I have a lot of patients who are like, well, I love to golf, but I can't golf anymore because I leak on myself every time I swing the club. So from that standpoint, I think incontinence is a very important topic to be addressed in the survivorship period. With men who have post-prostatectomy incontinence, one, it's about, again, there's that initial post-operative period where most men will have some degree of incontinence, and then you have improvement usually to about a year after the prostatectomy, in which after about a year, you've probably fully recovered the degree of incontinence that you have. And about 10 to 16% of men following a prostatectomy will be wearing more than a pad per day. So a fair number of patients will have some degree of leakage. But there are treatment options, which is always beneficial. And the treatment options kind of vary based on degree of incontinence. Sometimes it takes a little bit of additional workup to figure out how severe the incontinence is. And therefore, sometimes you might require a look in the bladder and look at that repair after the prostatectomy to make sure it's open with what's called a cystoscopy or a scope into the bladder. And then I'll typically do an examination with a partially full bladder to determine how well or how extensive the leakage is. And I do what's called a standing cough test, which is where I'll have the patient with a comfortably full bladder cough in front of me while I kind of hold a paper towel under the penis. And based on the stream after 5 coughs will give me a pretty good idea of how severe your incontinence is. If you cough once and you immediately have a strong stream, then your incontinence is fairly severe. But if you're telling me that you have leakage, but we do the cough test and you don't leak at all, that tells me you have a fairly mild form of post-prostatectomy incontinence. And from there, we kind of delve down 2 arms of treatment, both surgical, but one is what's called a male urethral sling, which is a procedure where you make a small incision behind the scrotum, find the urethra, and then place a mesh sling or hammock underneath the urethra to basically provide additional pressure and support to the urethra to increase the resistance to any urine that might leak out.
And that is different from a procedure called a urolift. Is that correct? Or is it a form of a urolift?
That is different than a procedure called a urolift, which is for benign prostatic hyperplasia, which is a procedure in which the prostate remains in place and is obstructing the flow of urine. Another kind of age-related prostatic urinary complaint, but is done for benign reasons and not for prostate cancer recovery reasons.
And the sling that you describe is a larger procedure.
It's a larger procedure, requires an anesthetic, but it is an outpatient procedure. It takes about 90 minutes. You'd have a catheter afterwards, usually overnight. And in most cases, I'll have you remove the catheter in the morning with the goal that you have that increased resistance to the flow of urine, which will hopefully decrease pad usage, if not make the patient completely dry. Okay. That though is something that is very patient selected, and for patients with mild incontinence. For patients with more severe incontinence after a prostatectomy, 7-8 pads a day, always wet. There's a different device, what's called an artificial urinary sphincter. Again, a procedure that's requires a general anesthetic. It's a 3-piece component, which is all internalized. There is a cuff that's placed around the urethra, which provides pressure to completely collapse the urethra. And then a pump device is placed in the scrotum that the cuff maintains constant pressure around the urethra. And when you pump the pump in the scrotum, it relaxes that pressure to allow 60 to 70 seconds to urinate, and then will automatically close back up to act like a normal urinary sphincter and prevent leakage, but in a artificial sense.
Yeah. So just to kind of repeat, it's a ring that kind of goes around the urethra internally.
Yes.
And that it's just basically pinches off the urethra, so no urine can flow from the bladder down the urethra. And then the individual who has it uses basically a switch that is internally in the scrotum, uses his hand to turn the switch, and it releases the pressure, allows the urine to then come from the bladder through the urethra and out the penis.
Yes.
And after about 70 seconds,
it automatically closes back up. Yeah, it's a very, sometimes it's difficult to wrap your head around exactly what's going on, but it's a mechanical device, and when you pump the device in the scrotum, you have that relaxation, kind of like what you would normally do when you were trying to urinate to relax, and then the bladder has time to push the urine out, and then automatically closes back up.
Yeah. So kind of like a little mini blood pressure cuff. You
Yeah.
know, you've all experienced a blood pressure cuff around your arm. You pump it up, it's pressing on your arm. You release the valve, it releases it. So a miniature version of that that's all totally internal.
Yes.
How successful is that? And are most men satisfied with
Yeah.
that?
So the artificial urinary sphincter, the cuff device, definitely has high success rates. I don't ever tell a patient I'm going to make you 100% dry, but I do anticipate, and the studies would suggest that 85 to 90% of men have a decrease in pad usage, down to about a pad per day. The other 10%, you can get down to mostly dry, but definitely life-changing in terms of the overall quality.
And as you mentioned, you wouldn't recommend this surgery unless somebody had pretty significant
Oh yeah, you can
incontinence.
usually tell the men who come in and have so much leakage that they need a sphincter. Other than that, the Sling procedure, which was the kind of hammock that lifts the urethra.
So what about the old school clamp on the outside of the penis?
Yeah, sure. The Cunningham clamp. It's always an option, but sometimes it's they can be uncomfortable. They can ultimately cause some external issues and pressure sores and ulcerations, and we try not to use those if we can, do something that's a little bit more satisfactory.
Okay. So let's switch gears now, and let's talk about treatment of erectile dysfunction in men who've undergone a treatment for prostate cancer.
Yep.
And we can expand it into talking about erectile dysfunction in general, but for maybe our group, we'll start with talking about erectile dysfunction that is a result of surgery and or radiation.
Yeah. So one of at least from a prostate cancer recovery, prostatectomy recovery scenario, something that's talked about a lot is what's called penile rehabilitation, with the goal of not necessarily treating erectile dysfunction, but returning you to natural erectile function as quickly as possible after a prostatectomy. A little bit of difference there, but basically,
good point. I mean, you have knee surgery, you don't you talk about how do you rehab a
Yeah.
knee surgery. You don't expect you're going to be bending the knee
Yeah.
fully right after surgery. How do you get it back to its normal function?
Yeah.
So
And I'm
penile
glad you
rehab.
brought up, knee implants, because that's kind of one of the things that I say to patients when we're talking about erectile function, and when it comes to, and we'll talk about this later, the penile prosthetic. But the penile rehabilitation is basically saying that you need to take a PDE5 inhibitor, Viagra, Cialis, sildenafil on a daily basis immediately following the prostatectomy, in the hopes that you will return to your erectile function as quickly as possible. It does really make sense in theory. A lot of the trials that have been done on it, which have been placebo-controlled, randomized trials to help this, don't necessarily show a benefit, but I do offer it to my patients.
Mm-hmm.
A lot of times, especially if there's a lot of concern about the erectile recovery afterwards, and because for the most part, those medications are fairly benign. Other than some side effects, they're usually pretty well tolerated by patients.
And so that helps improve the blood flow up into the penis that causes the erection.
Yes.
And so by taking the medication in the immediate post-op, it enhances the blood flow, filling the channels.
Yeah, increases blood flow back to the corpora, and also increases blood flow back to the nerve supply, which ultimately also needs blood nourishment to help restore itself. Now, when you talk about treatment for now diagnosed erectile dysfunction after a prostatectomy,
What about still talking rehab for just a second?
Yeah.
And penile pumps as part of
Yeah.
penile rehabilitation. Do you recommend that?
So,
And what is a penile pump?
So the vacuum erectile device, or the penile pump, is basically a device that you create a suction around the penis, create a vacuum around the penis, which ultimately pulls blood flow into the penis to allow for an erection. And they are utilized in some rehabilitation programs, partly to, again, increase that blood flow, basically try to reverse some of that scarring that can be created by the lack of blood flow, but also to help in some cases with perceived penile shortening, which can happen after a prostatectomy. Again, things that do seem theoretically to make sense and are fairly benign interventions, or with minimal risk. And so if there is a lot of concern there, we can always introduce the idea of the vacuum device into a rehabilitation program.
Okay.
When it comes to post-prostatectomy erectile dysfunction, really the treatment options are the same as erectile dysfunction for the general population, or someone who has age-related or diabetes-related erectile dysfunction. And so the treatment options kind of come into multiple arms, kind of going from more conservative to more aggressive therapy. You start typically with medications, or what's called a phosphodiesterase inhibitor, or PDE5 inhibitor, things that have been around since the 90s. Viagra, also called sildenafil, or Cialis, also called tadalafil. Some men will achieve erection with those medications alone. They are medications that need to be timed in terms of relation to sexual activity, usually anywhere between 30 and 60 minutes before desired activity. And the counseling always requires talking about the side effects, which are usually things like facial flushing, maybe some color changes or visual changes, headaches. And then from time to time, patients will complain of muscle aches and pains, but they remain the mainstay of therapy for erectile dysfunction, not only in the general population, but also in patients after prostate removal.
Or radiation.
Or radiation, absolutely. And then moving kind of down the line, you think about things that act more locally. So before PDE5 inhibitors existed, we had penile injection therapy, or what's also called intracavernosal injection, which has a higher percentage of men who respond to those. In the general population, about 70% of men will respond to Viagra, whereas about 90% of men will respond to injectable medication. The biggest issue for most men in using these medications is the fact that it's an injectable medication. So there's fear of needles. You have to get over the idea that you're going to be injecting something into your genitalia, which sometimes is a psychological barrier that some men.
What's the medication that's most commonly
It's called
used?
Trimix, which is a combination of 3 medications, all which are shown individually to promote erectile function. And there are multiple mixtures you can go with. There's also something called quad mix,
Okay.
but most of them have a prostaglandin in it, a very generalized PDE5 inhibitor called papaverin, and then another erectogenic medication, alprostadil.
Okay. So the patient would draw this up in a syringe,
Mhm.
kind of like if you're going to give an insulin shot.
Mhm.
You draw it up in a syringe. It's got a needle, probably a small needle.
Mhm.
And then where in the penis do you inject it?
Yeah, so somewhere between, well, you want to avoid the very top of the penis and you want to avoid the underside of the penis. So somewhere in that 10 o'clock to, I usually try and say aim for 10 o'clock to 9 o'clock, or on the other side, you want to aim for 2 o'clock to 3 o'clock.
Mm-hmm. So on the side, and the needle goes all the way into the hub, or it's not a subcutaneous injection.
So you want to inject it into the corpora cavernosum, which is the erectile body of the penis. And so typically the needle is only about a half an inch long. So if you get it all the way to the hub, you're going to get it into the erectile body, and that's where you inject.
Okay. And yeah, the thought of that is not pleasant.
There's a little bit of pain associated with the injection site.
The thought might be more
the
painful.
thought is
than
probably
the
more
actual,
painful than the actual procedure.
But I would imagine that once you've done it a few times, you kind of
Yeah, absolutely.
get used to it.
We always do what's called a trial dose in the office. So you'll come in and we'll order a small dose of the medication for you first. You come into the office, we teach you how to inject yourself, and then monitor your response. And the good part about injectable erection therapy is that you can kind of titrate the dose yourself. If you don't get a good response with, say, 5 units or 0.05 cc's of the medication, you can increase to 0.1 or 0.2. But as you kind of start escalating that number of injections, the likelihood is that you're probably not going to respond great to injectable medication.
And then how long does the erection last?
So the erection lasts through intercourse, but occasionally, and one of the big risks of injectable medications is that idea of priapism, or a painful erection that lasts longer than 4 hours. And it probably is the most common cause of priapism, in the United States, is injection gone wrong in a certain regard, which then requires you to either call your urologist or present to the emergency department.
So again, if one of the risks is that you get an erection that doesn't go down, and what is the health consequence of having an erection for over 4 hours?
Yeah, so what ultimately happens during an episode of priapism is that the blood flow comes in and it can't come out, and therefore new blood flow can't come in, which ultimately leads to what's called ischemia, or poor oxygenation of the tissue, which can ultimately cause essentially erectile dysfunction, severe erectile dysfunction, which causes scarring of that corpora cavernosum, or those erectile bodies of the penis.
So if someone injected, well, regardless of how much they injected, but they have an erection for over 4 hours and they go to the emergency room, what's the treatment?
So the treatment kind of escalates depending on whether or not the erection goes down. So you initially would do what's called irrigation, which is where, one, we would numb your penis first, because obviously the idea of doing anything to your penis causes a little bit of psychological trauma. So we would try to numb things up as best we could. But then you would try to irrigate that bad blood out, or that old blood out, so that new blood can come in. So you put a needle into the penis and then would have to evacuate some of the old blood. And then ultimately give an injection of a reversing agent, or phenylephrine, which is a medication which causes collapsing of the blood vessels and allows the blood vessels to push all that blood back out of the penis. Typically, you have pretty good response to that. And you don't need to go on to more aggressive therapy, but sometimes you have to go to surgery to correct it.
Okay. So we talked about oral medications. We talked about injections. What are some of the other treatments for erectile dysfunction?
So there is something called Intraurethral Alprostadil, which is a medication that goes directly into the meatus, or the hole of the penis where you pee from. It's a kind of a pellet-shaped device that you push a pellet down into the penis, and then that medication acts locally, which a lot of men don't like so much because sometimes it causes some burning and penile pain. And for the most part, I feel like men respond better to injections.
Okay. Is it the same type of medicine as in the injection, or the same type of medicine?
It's similar.
as in-
So it's a prostaglandin. So it's
Okay.
alprostadil, which acts by relaxing the blood vessels and bringing blood flow into the penis. The vacuum device, kind of what we already talked about, when you not used in a penile rehabilitation sense, but for actual erectile function sense. Again, you squeeze the device to pull a vacuum and pull the blood into the penis, and then would have to use kind of a rubber band device to keep the blood in the penis to
So it's
allow for
basically a
intercourse.
cylinder that goes over the penis. You suck the air out of the cylinder, which pulls
Mhm.
the blood up into the penis. And then you put a rubber band down at the base of the penis where you take the device off, use a rubber band to keep the blood in the penis, and then
use it
do
for intercourse
proceed
or
with
whatever,
intercourse.
whatever sexual activity you desire. The biggest issue with that is if you've ever put a rubber band really tight around your finger for a while, your finger goes numb, it turns black and blue, and it gets fairly uncomfortable. The same thing happens to the penis. So guys complain about, decreased sensation, and then afterwards, your penis is black and blue for a while. Most of what I've found is that you buy the vacuum device, you use it once, and then you put it in the closet for someone to find later and go, "What's this?" One of those scenarios.
Okay.
And then kind of the end treatment, and what I consider a very good option, especially in the post-prostatectomy setting, is what's called a penile prosthesis, and that's where when you brought up the knee replacement, what I kind of use as a metaphor for the penile prosthesis is you have a pathologic diagnosis to your knee, so you replace the knee. Well, now you have a pathological diagnosis to your penis, so you replace the parts of your penis that need to be corrected. There are multiple devices on the market. One is what's called a malleable prosthesis, where you just take those erectile bodies of the penis and put basically a stiff rod in there. But a lot of guys don't like that because then you always have an erection and you're always walking around with a fairly stiff penis, which can be problematic for some men. And so there's a very good device, what's called a 3-piece inflatable penile prosthesis. And it has similarities to that artificial urinary sphincter, where it's a 3-piece device. You have 2 cylinders that go into the erectile body of the penis. You have another pump that goes into the scrotum, and then the third piece is a small fluid reservoir, which usually goes somewhere underneath the muscles of the abdomen or sometimes in front of the bladder. And what happens is when you pump the device in the scrotum, the fluid transfers from the reservoir into the tubes or the cylinders. The penis goes up to give you an erection. It stays up for as long as you need it to stay up. And then when you're done with sexual activity, you hit a button on top of the pump in the scrotum and the device goes back down. So essentially mimics normal erections, but from a mechanical standpoint.
And as you said, all of that is internal, so
Yes.
you can't see it externally. And the gentleman who has it uses his hand to just turn to activate it.
Yes.
With a sort of a switch that's in the scrotum, and then when ready to deactivate it, again, just uses the switch and takes the fluid back into his reservoir.
Yes, that's correct. Again, surgical procedure. A small incision is made either above or below the penis, depending on how the surgeon would prefer to do the procedure. The device is inserted through that incision. Recovery, it's done as an outpatient procedure, but sometimes there's a observation period in the hospital just to ensure that the patient can urinate well afterwards, a lot of times. but then goes home. Or at least my protocol is I bring you back to the office about a week later just to check on the incision and make sure things look okay. And then I'll have you start pulling that pump that's in the scrotum down. And then about 2 weeks later, I'll bring you back and show you how to inflate the device.
So let's say a month, 2 months afterwards. So men who have this device, do they experience orgasm?
Yes. So often what is found is men complain of a decreased sensitivity, and not so much because there actually is decreased sensitivity, but now they've have a device that they can pump up immediately when they're ready to have sexual activity, and they don't have to go through that pre-sexual activity experience, foreplay, things like that. And so there's a prolonged period to orgasm because now they have an erection that's usable immediately, and then can be used for a longer period before they experience that orgasm, but still able to have an orgasm.
Okay. Any other forms of treatment for erectile dysfunction?
There are other forms, and I guess just to talk about one that's been advertised a lot, which is called shockwave therapy to the penis. Definitely a lot of commercials out there right now, and there's a lot of confusing information for a lot of men. I will say that for men with general erectile dysfunction who have mild disease, these therapies can work. But for men who are post-prostatectomy erectile dysfunction, I would not recommend it.
Okay. And so that's a form of shock, electric, ultrasound shock?
Yeah, so it's ultrasonic shockwave therapy,
okay.
similar to therapy we use to treat kidney stones, but at a much
Okay.
lower intensity. Basically, it's a focused form that creates micro pulses to the erectile body of the penis with the goal of stimulating the blood vessels to create new blood vessels in a process called angiogenesis, which then ultimately improves blood flow into the penis.
And right now, that's not like FDA approved, or and let me say, insurance companies have not
Insurance
yet picked
companies
up
do not cover it.
Do not cover it.
It's gaining popularity. It is a treatment that we are now offering at the Urology Center of Iowa. But again, for those men with mild erectile dysfunction, and not for men with more severe disease who require injections or something that is caused by other pathologies like patients with diabetes, or patients who are post-prostatectomy or radiation.
And again, the name of that procedure?
It's called low-intensity shockwave therapy,
Okay.
which is different from a lot of advertised therapy, what's called Gaines wave or radial wave therapy. That has not been proven to have any sort of benefit in forms of treatment of erections.
Okay. Oh my gosh, time has flown by. Let's open it up for questions.
Absolutely.
Little Q&A. And so if you are watching us live streaming, if you could put your question in the chat box. And do we have any brave souls that have a question in person here for Dr. Dornbeer?
I'll be the brave soul. And man, I don't want to get prostate cancer after listening to this. So you didn't touch upon this yet, but the nutritional end. Okay, so there's two parts of this. So what can I do nutritional wise to minimize my risk of prostate cancer? Then the second question of it is that I have prostate cancer, and it's the one I can live with, throughout the years. Is there something nutritional wise I should be doing to minimize that so that it doesn't get worse?
Absolutely. So prevention of prostate cancer is, from a nutritional standpoint, there is an association with obesity. So men with higher BMIs have a higher risk of developing prostate cancer. Now, the overall general then dietary recommendations would be similar to all of those healthy lifestyle choices that that we try to promote as much as we can in terms of increasing your physical activity, avoiding red meats, and an overall westernized diet and more of a Mediterranean diet. But there's not a specific nutritional recommendation that prevents prostate cancer. From a post-diagnosis standpoint, unfortunately, once you have a diagnosis of prostate cancer, there's nothing that necessarily keeps it at bay.
Okay. My next question is, I have prostate cancer and I'm in my 80s and 90s. Should I even care about getting treated and going through the different things that you mentioned tonight?
That's a really good question. And I think what we would often recommend for a patient who would be diagnosed at that time, depending on their stage of diagnosis. So if we're talking about a gentleman in his 80s with an elevated PSA who really wants to make sure that he doesn't have prostate cancer, is ultimately diagnosed with a low risk, intermediate risk prostate cancer, then we would definitely recommend active surveillance for that patient. What we have often found is that men in that scenario will come to us with new onset urinary symptoms, and a PSA will be drawn, and they'll be closer to the 150 range or 100 range, which is concerning for advanced prostate cancer, in which case, once a diagnosis is made and we've determined its overall stage, would recommend some sort of treatment, which would usually be hormonal treatment.
So basically, it's the severity of it.
Absolutely.
Yeah. And I would also say it also depends on the other health issues that the gentleman has. So we try to estimate what do we expect, even without the prostate cancer, one's survival is going to be, life expectancy. So in the world of prostate cancer, if someone, based on their heart disease and diabetes and strokes and all of the other diseases, has a life expectancy of less than 5 years, then unless they had advanced cancer, we wouldn't think that providing them cancer treatment for a cancer that's confined to the prostate would provide them benefit over the course of their lifetime. So that's an issue that sometimes comes up, that somebody gets a PSA done, and they're already quite old and have so many other health problems that working up the prostate cancer, it would be unlikely to provide them benefit. So wordy way of saying, yeah, it depends. How long do we think you're going to live based on your overall health? That factors into whether
Absolutely.
one decides to do treatment. We have one last question.
Very timely question. RAGBRAI is taking place. Believe it or not, I mean, this myth still survives about riding a bicycle and potential harm to the prostate. Is that just a myth?
There is some, and I have not brushed up on some of this data recently. There is some idea that it can potentially cause pressure to the prostate, which can ultimately lead to an elevated PSA, but not necessarily cause or be implicated in prostate cancer per se. The other thing that I see from time to time from a reconstructive standpoint, because outside of cancer, you deal with urethral issues or urethral stricture disease, and sometimes depending on how you ride the bike, you can put a little bit more pressure on your urethra or on your prostate, and so form matters in a certain regard.
Yeah, I would say, not being a urologist, but having done research, because I ride my bikes a lot, and there's lots of myths. Or what's the best saddle, and can the saddle cause erectile dysfunction? Can it cause prostate cancer? Can it cause issues? Anybody who's ever done a long bike ride, any man who's ever done a bike ride, has probably experienced a loss of sensation of genitalia that can just happen from the pressure of riding bike. I mean, probably everybody's experienced your hands going numb from the pressure of riding a bike. The same thing can happen to genitalia. The literature, a review of literature, fails to show that there's actually that bike riders and those who ride a long time have an increased risk of erectile dysfunction or prostate cancer. So statistically, that doesn't appear to bear out. Nobody's done a randomized prospective study, but probably the health benefits of riding a bike and aerobic activity are more likely to be good for sexual health than having a
Absolutely.
negative effect.
I would never discourage someone from riding a bike for any sort of genitalia related issue. That's for sure.
Well, I'm going on rag ride tomorrow. So thank you so much for that seal of good health. So I thank you, Dr. Dornbeer. Thank you for coming back to Des Moines with your advanced training and being able to provide urologic care to men here in central Iowa. Thanks all of you for attending the talk. If you know someone who might benefit from listening to this, this will be on the Above and Beyond Cancer YouTube channel for view on demand, and it'll also be available on the Mercy One Cancer Center website. Thanks for joining this evening. Please come again next week. Thanks, everybody.